And now to start our first topic entitled, Hypokalemia is Fatal. Treat Right Not Light, which is a CME grant sponsored by Zulig Pharmaceuticals.
Our speaker is a Fellow of the Philippine College of Physicians, Fellow of Philippine College of Cardiology, member of Philippine Society of Cardiac Catheterization and Intervention. Core Trainer, Internal Medicine in University of Perpetual Help Medical Center, Biñan. Assistant Training Office, Adult Cardiology in University of Perpetual Help Medical Center, Biñan. Let us all welcome Dr. Ray Albert R. Cabigan.
Good afternoon, everyone. Thank you for having us this afternoon. This afternoon, I've been tasked to discuss with you the clinical approaches in hypokalemia. I will be sharing my slide. Okay. All right. So hypokalemia is fatal, and it is important for us physicians to be able to treat it right and not light. Again, I am Dr. Ray Cabigan, and these are my disclosures. Hypokalemia is an illness that's defined as low potassium levels, or typically less than 3.5. And as you could see from this line graph, you would see that as the potassium levels stray from 4.4 to 4.5, you would also see that the concomitant hazard risk of mortality significantly increases, okay, whether it be towards the lower end or towards the higher end of the potassium levels, the risks increase. And this is across the spectrum of patients who have renal disease. So whether the renal function is a little bit higher or whether it is low, for as long as the potassium levels are deranged, patients are at risk of dying because of derangements in this particular element. And there has been studies concerning hypokalemia, and they have also found that while the risks of dying or having adverse events related to hypokalemia increases as the potassium levels decrease to less than 3.5 and increase to more than 5, by correcting the potassium levels of these patients, we are actually able to significantly decrease the risks of these patients in dying. Okay. Which brings us the very important task of being able to maintain the potassium levels of our patients within the desirable limits. And so with that, these are the objectives of this afternoon's lecture. Okay, so potassium is a strictly regulated electrolyte in our body. So the potassium that we consume is typically around 70 to 100 mg per day. And that would be distributed extracellularly and intracellularly to very strict levels. And the extracellular potassium is the one that is excreted. So 90% of that is excreted in the urine, and the rest is excreted in the stool. So if there is excessive losses, either through LBM or through the urine because of diuretics, we would expect that there is also a significant decrease in the extracellular potassium levels of our patients. Now, again, the definition of hypokalemia is a potassium concentration of less than 3.5. The intracellular concentration of potassium usually ranges from 140 to 150 millimoles per liter, and the extracellular concentration of the potassium is about 3.5 to 5.0, and it's considerably less. So this is actually the potassium levels that we are able to monitor in our patients when we do the blood tests. And the decrease of 1 mg per liter means a deficit of about 200 to 400 mgs per liter, and a decline from 2 to 3 mgs signifies a deficit of 400 to 600 mgs per liter. And hypokalemia is relatively a devastating illness depending on the degree of hypokalemia. So the lower the potassium levels are, the more symptoms that the patient will experience. So typically, hypokalemia would present as symptoms of generalized weakness, muscle pains, lethargy, and constipation. So these are symptoms that we could see among patients who have had undergone surgery. typically those who underwent extensive bowel surgery, wherein they would require also bowel rest, you would notice that if their potassium levels are less than 3.5, you would note that there's a longer period for these particular patients to recover or to have significant bowel movements that would facilitate the passage of liquids through their bowel. So they are the ones that would present with bilus secretions from the NGT. These are patients who have longer time to recover after bowel surgery. So it's important for us to be able to maintain the acceptable potassium levels for these groups of patients. If it's less than 2.5, these are the patients that we see in the emergency room who claims that they are unable to walk. There's marked muscle weakness. There's for severe cases, there are patients with respiratory failure. Others have ileus paresthesia or tetany. And for our specialty for that, for in particular, some of the patients would present as arrhythmia, and those are particularly fatal. So once they develop the ventricular arrhythmias related to hypokalemia, those patients are relatively already in a critical condition, and the need to correct it rapidly becomes all the more important. So similarly, when patients develop hyperkalemia, they may have almost similar symptoms. They may have tingling sensations, they have decreased reflexes, they may also have paralysis and muscle weakness. There may be bloating, and patients tend to be nauseated. In terms of cardiology, these patients, usually patients with end-stage renal disease, when they have hyperkalemia, they also have bradyarrhythmia. Some would present as a complete heart block. Some would present as high-grade AV blocks or second-degree AV blocks. But after the potassium levels have been corrected, they do return back to normal sinus rhythm. And the reason why potassium has those effects is because they have the effects on hyperpolarization in the muscle groups of the patient. So in the neuron, the muscle, when potassium levels are low, when there is hypokalemia, the threshold for depolarization actually increases. So there is the delay in the action potential related to the muscle groups of the patient. So that's why they have generalized weakness, they have muscle weakness. But in the heart, aside from changing the threshold for depolarization in our patients, it also has an effect on the repolarization phase of the patient, wherein because of the low potassium levels, the repolarization phase is relatively a little bit shortened, and it predisposes patients to hyperexcitability and also risk of after depolarizations, meaning during the repolarization phase, it becomes more excitable and easier for it to be depolarized again before it has completed its repolarization phase. And when that happens, it increases the risks for ventricular arrhythmia. So the consequences of hypokalemia is that it can present with polyuria, polydipsia due to decreased concentrating ability of the kidneys. And there may also be glucose intolerance because insulin release is regulated partially by plasma potassium. So if there's low potassium levels, patient might not respond well to the insulin that we're giving them. So in general, there is about 10 milligram per deciliter increase in glucose concentrations for every 1 mg decrease in plasma potassium levels. So how does the body handle potassium? So most of it, as you saw earlier, about 90% of the extracellular potassium is excreted to the urine. So it's metabolized by the kidneys mainly. So there are two main aspects. There's the control of transcellular distribution of potassium ions, and there's regulation of potassium excretion by the kidneys as well. The physiological factors influencing potassium secretion, most of them is due to the available plasma concentration of potassium and because of aldosterone. So it's the major physiologic regulators of potassium secretion. But then there's also the tubular flow rate, the presence of hydrogen ions, and of course your antidiuretic hormones. So potassium handling along the nephron occurs mostly in the proximal convoluted tubule. About 20% happens at the metabolism, whether it's excreted or it's reabsorbed. happens in the thick ascending loop of Henle, and the rest occurs in the distal convoluted tubules. So in the proximal convoluted tubule, a large component of the filtered potassium is reabsorbed by the proximal tubule, particularly through the paracellular diffusion driven by luminal positive charge. So it's more positive in the lumen, less positive in the interstitium. So it kind of pulls it towards the interstitium, away from the lumen of your nephron. On top of that, there are also receptors involved in the potassium metabolism. So the shift in lumen potential from negative to positive in the latter portions of the proximal tubule provides an additional driving force of potassium reabsorption. Once the urine reaches the thick ascending loop, there are other mechanisms involved that helps reabsorb potassium into the interstitium. So majority of it is filtered potassium that escapes reabsorption, the tubule, reabsorbed in the thick ascending limb by both the transcellular pathways and paracellular pathways. Okay, the transcellular pathway involves the sodium chloride and sodium potassium ATPase. So wherein there is reabsorption of your sodium and your chloride and your potassium, and then the potassium here is actually recycled through the ROMK and back into the lumen in order to maintain that luminal positive charge in the nephron. And once it reaches the distal convoluted tubules, there are again various receptors and various mechanisms that help maintain balance in the interstitial potassium levels of our body. So how does hypokalemia occur? Why does if there are so many mechanisms as to how potassium could be regulated or maintained within a normal limit in our body, how does hypokalemia occur? So there are basically three main pathways as to how hypokalemia may occur. One of the most common one is the abnormal losses or increased secretion. So for us cardiologists, the reason why our patients do develop hypokalemia is because of the diuretics that we give our patients. So for example, patients who have heart failure, we give them furosemide, and furosemide can cause, it's a diuretic, and it can cause potassium losses through the urine. For some patients, they have gastrointestinal losses, those patients who are having LBMs. They could also have lower potassium levels. As mentioned previously, about 10% of the extracellular potassium is excreted through the gut. So about if a patient has recurrent bowel movements, and they could also have hypokalemia. So there may be renal losses as well, and there may also be due to dialysis. For some patients, especially those who are bedridden, who are in need of constant care or is very dependent even on feeding, specifically for patients who have dementia, they may have inadequate intake. Okay, so that inadequate intake may lead to hypokalemia as well. So too little intake of potassium, so therefore the patient loses its source of potassium, leading to hypokalemia. For some patients who are maintained on TPN, again, these are patients who have had extensive bowel surgeries or complex bowel procedures wherein they need to have several days of bowel rest. These patients are typically maintained on TPN. So they do tend to have episodes of hypokalemia. And that hypokalemia may be detrimental to these groups of patients simply because it interferes with the metabolism that would allow the bowels to recover and move after surgery. In some cases, there is intracellular shift. So these are patients who are given your beta-2 sympathomimetics or beta-2 agonists, and in patients who are being given insulin, specifically those who are on insulin drips for a variety of reasons, whether it be because of uncontrolled blood sugars or patients with DKA or patients with ketosis or patients with uncontrolled blood sugars. So all of these factors may contribute to hypokalemia. So what is hypokalemic periodic paralysis? So as the term implies, it's periodic or recurrent episodes wherein patients develop hypokalemia leading to paralysis, specifically, more commonly, the lower extremities. So it is a relatively rare disorder characterized by muscle weakness or paralysis due to sudden movement of potassium into the cells. So it may be triggered by exercise, stress, but sometimes it's also related to patients who have hyperthyroidism, so usually in men. And it may also be familial. So that rapid intake of potassium depletes the extracellular extracellular supply of your potassium, and it also interferes with depolarization of the muscle groups. So when it interferes with that, then the patient would end up having paralysis. But once you've corrected it back into desirable levels, the patient would gradually recover muscle movements. So for the drug-induced hypokalemia, these are just some of the common medications that may be given to the patients that may inadvertently induce hypokalemia. So we do have good intentions for giving medications, but sometimes its adverse reaction is to reduce the potassium levels of the patient. Again, for us us cardiologists, usually our medications that cause hypokalemia are under the diuretics, particularly your furosemide. But sometimes there's also medications that cause intracellular shift. So it takes the extracellular potassium and puts it inside your cells. And therefore, when you check the potassium levels of the patient, you would see hypokalemia. And some of them is because of the common medications like your salmeterol or salbutamol or your beta-2 agonists. And it may be because of theophylline. It may be because of insulin that we're giving the patient for various indications. Okay, so it's also the reason why some of these drugs are given as temporizing measures for patients who have hyperkalemia. So we give them in order to cause intracellular shift to reduce the potassium levels of the patients to more desirable levels. So for patients who are being given sorbitol or sodium polystyrene sulfonate, there may be excessive fecal elimination of potassium. Okay. So sometimes it's also genetic. We have the Barter's syndrome. So the Barter's syndrome, the site of the problem is your thick ascending loop of Henle, wherein there is an abnormal NKCC2 in your ROMK and chloride channels, and there is sodium wasting and volume contraction. So there is increased activity of your RAAs. Patients tend to be hypertensive. Sodium is reabsorbed by your collecting tubules, and there is also excessive secretion of your potassium and hydrogen ions, resulting to metabolic alkalosis and at the same time hypokalemia. Okay, so for these particular patients, again, it's important for us to correct the underlying problem and provide sufficient potassium correction to these patients to avoid adverse events related to hypokalemia. Okay. So syndrome that is closely related to Bartter syndrome is your Gittelman's syndrome, wherein the problem now lies in your distal collecting tubules, and it's the abnormal NCCT. So again, the features of this syndrome is somewhat similar to that of your Bartter syndrome, except that the problem is in your distal collecting tubules. So when we investigate hypokalemia, the common tests that we perform are the blood tests, your serum potassium, and of course, you would want to assess if the patient has a renal problem that may cause potassium problems in the patient, whether hypo or hyper. So if a patient has elevated creatinine levels, elevated BUN levels, the patient may have AKI or AKI on top of CKD or a pre-existing CKD already that may cause hyperkalemia in the patients. So sometimes it's also related to various electrolyte deficits, in which case you might consider either losses of the electrolytes through secretion or poor intake of the patient, resulting to various electrolyte imbalances that may include potassium levels. The blood gas is also important, and as you can see, blood gas like patients who have alkalosis may actually have Barter's or Gittelman syndrome. Patients who have acidosis may have other confounding metabolic problems that may contribute to changes in the levels of potassium in the blood of the patients. So urine tests are also useful. These are tests that ideally should also be done in patients who have recurrent episodes of hypokalemia in order for us to determine if it's actually in the urine that the potassium levels are lost. So if there's elevated urine potassium, elevated potassium levels in the urine, then that would tell us that maybe the reason for the hypokalemia of the patient is due to renal losses. Okay. So the 24-hour urine collection is a very useful tool in order for us to assess how the kidneys handle the potassium levels of the patient. So if we see that it is less than 25 to 30 mg per day, it's a normal response to potassium depletion. But if it's more than that, then it may be, it tells us that there might be significant mishandling or significant losses of potassium through the urine. So higher values suggest a component of kidney potassium wasting. And we could also do a spot urine potassium. The levels that is considered here is of course quite different from that of the 24-hour urine collection. 5 to 15 mg is consistent with extrarenal cause of hypokalemia, but if it is more than 40 mg per liter, it implicates that the kidney is the underlying cause of the hypokalemia. Okay. The urine potassium to creatinine ratio is another useful tool in diagnosing or determining how the kidneys handle potassium levels or potassium excretion in our bodies. If it is less than 13, it suggests an appropriate response to gastrointestinal potassium loss and remote use of diuretics. So it's decreased dietary intake and potassium shift to cells, but higher ratios would imply an inappropriate response by the kidney to the above conditions. So if we're giving patients diuretics, the losses should still be less than 13 unless you're giving high doses of your diuretics, or the patient has been maintained on diuretics. It may lead still to excessive urine losses in the urine, potassium losses in the urine. But normally the response of the kidney would be to save some more as much potassium that it can to avoid hypokalemia. So if there's too much losses in the potassium to creatinine, potassium in the test, and that would tell us that there is inappropriate response by the kidney. Through ECG, there are various ways in which we could evaluate the effect of potassium on the heart, and specifically on the electrical conduction of the heart. Normally, when you look at patients' ECG, you would see the P, the QRS, and the T waves. Sometimes you may have a U wave, and you would note that this is what the normal ECG waveform looks like. But in patients with hypokalemia, there may be slightly prolonged PR interval, okay, and there would also be ST depression. So there's the shallow T waves, there's the ST depression, but it does not necessarily mean that the patient has ischemic heart disease. The reverse is true with hyperkalemia, wherein some patients may be mistaken as having ST elevation MI, but it's actually just a tall peak T wave, representative of significantly elevated potassium levels. So the ECG changes related to hypokalemia are typically the following. If it's 3 to 3.8, you may have a flattening or inversion of your T waves. If it's between 2.3 to 3, then there may be QT prolongation, there may be mild ST depression, and there may be ventricular extrasystoles. If it's less than 2.3, it increases the risk of patients developing ventricular arrhythmias. You may have your torsade, and you may have ventricular fibrillation. Some patients would have ventricular tachycardia. That is why the potassium levels of patients who have cardiovascular disease, especially those who have very low ejection fraction or EF of less than 35%, it's important for us to maintain them on a target level of 4.0 to avoid arrhythmia. Yeah, again, the lower the potassium levels or even the higher the potassium levels of the patient beyond 4 to 4.5 or 5 in some cases, the risk of fatal arrhythmias also increases for patients who already have an existing cardiovascular disease. It's highest risk for them. But even if the patient does not have any cardiovascular disease, they may still develop arrhythmias. So it's important for us to always check the potassium levels of our patients. So situations that increase the proarrhythmic risk of hypokalemia are the following. So note that antiarrhythmic agents, including your class 1 or class 3 agents. So class 3 antiarrhythmic agents is your amiodarone. So if you give amiodarone to your patients, you typically increase the risk of arrhythmia if the potassium levels are not within desirable limits. So if it's too low, if it's less than 3, and it continues to go down, you're increasing the risk of these patients in developing ventricular arrhythmias. And digitalis also increases the risk of having arrhythmias in patients who have low potassium levels. And again, if you have signs that the patient already has cardiovascular anatomically, you already have signs of cardiovascular disease, whether it be left ventricular dilatation, like what we see in patients with dilated cardiomyopathy, and patients with HFrEF or heart failure with reduced ejection fraction, the greater the risk that the patient may have arrhythmia. In some patients, specifically younger patients, they may have a hypertrophic cardiomyopathy, not necessarily obstruction. If they have significantly very thick left ventricular muscle, they also have higher risk of developing arrhythmia. And this emphasizes the need for us to maintain a very strict level of potassium, and that's around 4 to 4.5 in our patients who have cardiovascular disease. So laboratory investigations, there are special tests that could be conducted in order for us to determine the underlying causes of renal losses of potassium. We have to assess the renin and the aldosterone as well as your cortisol. Now, specifically, if you're going to look at these tests, it's actually a test that is used for patients who have aldosteronism, and of course, we would want to check if the patient also has the Cushing syndrome. So, just a little bit on hyperaldosteronism. This is a common cause of hypertension among patients who are less than 40 years of age. They typically present with resistant hypertension. Okay, so they need a lot of antihypertensive medications in order to maintain a normal blood pressure. But at the same time, about 25% of these patients may present with hypokalemia. And that may give us a clue that these young hypertensives might be suffering from hyperaldosteronism as the cause of hypokalemia and hypertension. So hence the importance of us in checking these hormones. Okay. Well, once we've diagnosed hypokalemia, what do? How do we manage the hypokalemia? Of course, it's always important for us to manage the underlying cause of the hypokalemia. If it's because of the diuretic, then we stop the diuretics. If it's because of poor intake, then we have to improve the intake of the patient. If it's because of other disease entities like your aldosteronism, then you have to correct the aldosterone, give them the drug of choice, and you should be able to correct the potassium levels of the patient. So there has been algorithms that has been created by various journals and even by PGH. Okay, so they presented here a very good flowchart, and I found it really very useful in the treatment of our patients with hypokalemia. So here, if the potassium levels is less than 3.6, you have to assess if there are signs warning signs that has to be corrected. Or it gives us a sense of urgency if we have to immediately correct the potassium levels of the patient. So, for example, I had a patient who has heart failure with reduced ejection fraction and found that his potassium levels were already about 2.8, because we've been giving this patient loop diuretics for the past 2-3 days. Okay, and while the patient was receiving it, we noted that the patient has been having greater incidences of premature ventricular contractions. Now, luckily, this patient did not have any ventricular tachyarrhythmias like a ventricular tachycardia or ventricular fibrillation, but that did tell us that that we should take action immediately to avoid patients having those kinds of arrhythmias. Because the moment that heart failure patients develop ventricular arrhythmias, their risk of dying is actually very high. Okay, so we have to evaluate if there are any warning signs, ill use, you have arrhythmias, you should be able to correct it immediately. So there are also pseudo hypokalemia. If that's the case, then you don't need any treatment. If there's evidence of decreased intake or transcellular shift, then you have to correct the underlying cause, as we talked about earlier. If there are none, then you have to assess if the losses is because of the urine or renal losses. So you could use your urine potassium to creatinine ratio. If it's low, there might be extra renal losses, and you correct the underlying cause. If it's more than that, then it's significant renal loss. You assess if there are if the patient has elevated blood pressure, hypervolemia, then you have to evaluate for the other confounding associated conditions that may need correction. So this would be your hormonal problems, primary hyperaldosteronism, secondary hyperaldosteronism, renal artery stenosis, Cushing syndrome, etc. So if there are no signs of elevated blood pressure or hypervolemia, then we have to check the acid-base status of the patient. So if the patient has acidosis, you have to treat it appropriately. If there is concomitant hypomagnesemia, by correcting the hypomagnesemia, we might be able to also be more effective in the treatment of hypokalemia. If the patient has alkalosis, then our consideration may be upper GI losses through vomiting. It may be because of your diuretics, or it may be because of your Barber or Gittelman's syndrome. Okay, so the assessment of the urine potassium is always very important, and by doing so, we would be able to somewhat target or identify the underlying cause of the hypokalemia. And once we have identified it, but we could treat it appropriately, not just by giving potassium correction, but also treat the underlying cause to avoid recurrent episodes of hypokalemia in our patients. So how do we treat it? We treat it by decreasing the potassium losses. So if the patient is on diuretics, you might want to consider reducing the diuretic doses in order to also decrease the potassium losses. If of course, you would want to replenish the potassium stores, either through oral or through IV, depending on the urgency of the therapy, or depending in the ability of the patient to tolerate oral correction of potassium. So we should also evaluate the potential toxicities associated with the correction of hypokalemia. Note that if you overshoot the treatment of potassium, you also introduce the patient to other symptoms associated with hyperkalemia. And of course, determining the underlying cause of the hypokalemia is very important, so that we would be able to treat it and avoid future episodes of hypokalemia. So the treatment may be oral and IV, as I mentioned earlier. And oral is, of course, more safe and more effective, and can be dosed at 100 to 150 mg per day. And the IV potassium may be needed for patients who are unable to take potassium tablets or potassium syrups per orem, or those who cannot tolerate the tablets. So if the potassium deficit is substantial enough to cause cardiac arrhythmia, you might want to correct the potassium levels through IV at a more rapid rate. So these are patients who have respiratory paralysis or rhabdomyolysis. Intravenous potassium, however, should be administered at no more than 20 mg per hour. So at 20 mg per hour, there are various reasons for this. It's because, one, it may be quite painful for the patient, especially if it's given through the peripheral line. And number two, you might overshoot. And number three, the faster that you introduce potassium, you might inadvertently also induce symptoms of hyperkalemia, and might also induce inadvertently arrhythmia in your patients. So the principles are as follows. Serum potassium it's not an exact indicator of your total body potassium deficit. After all, there is still the consideration of the intracellular potassium levels of the patient, but correction of the metabolic acidosis without potassium supplementation may cause worsening of hypokalemia. So IV glucose administration can cause potassium levels to fall, and if you give too much potassium may result to hyperkalemia. So coexisting electrolyte imbalance, specifically for your hypomagnesemia, may also prevent correction of hypokalemia. So error on undercorrection, especially in the elderly and those with renal insufficiency, can also result to new problems for us physicians and for the patients. So how do we supply potassium? You have to decrease 1 mg per liter. A decrease of 1 mg per liter means a deficit of about 200 to 400 mgs of potassium. So we have to check the osmolarity and the acid-base status of the patient, which is why aside from assessing the serum potassium of the patient, we also have to check the ABG of the patient. So if the patient has DKA or if the patient has acidosis, it may mask the potassium deficient condition of the patient. And we should avoid sugar-containing IVF if we are correcting your potassium levels. So there are available salts that we can give our patients by mouth. You have the potassium chloride. It's readily absorbed and available as a liquid, whether 10% oral KCl, but it does have an unpleasant taste. Some patients do not tolerate it. They vomit it because of the very poor taste. And there is the tablet form. It's more tolerated. There are tablets that are really small in the rule form that is more tolerated by patients and has less adverse effects in terms of GI symptoms for the patient. So potassium phosphate may be used to replace phosphate losses, and potassium bicarbonate may be used in the setting of metabolic acidosis. So for the residents or for those who are in training, it's important for us to compute the potassium deficit of the patient in order for us to determine how much potassium we're supposed to give our patient. So the estimation of potassium deficit is as follows. If the patient has a 3.0 mg per liter, the total body potassium deficit is around 200 to 400. If it's 2.5, it's 500 for patients who are 70 kilos. If it's 2.0, then it's relatively around 700 mg if the patient is a 70 kilogram individual. So oral therapy, again, is generally safer. The degree of potassium depletion does not correlate well with the plasma potassium levels. And KCl is usually in the preparation of choice, either as syrup or as durul. So Kalium durul is a very well-tolerated potassium chloride tablet for patients. It's small and it provides us with 10 mg of KCl. Okay. So for IV therapy, for those who are developing severe paralysis, or for patients who have experienced arrhythmia because of hypokalemia, IV therapy is important. Okay. So we should be able to give it to patients who are unable to take anything by mouth. And the maximum rate, of course, should not be more than 20 if it's in the central line. So if it's central line, straight to the heart. But peripheral, it's around 10 mg because of the tolerability. It's very painful. If you've given potassium in your patients already, you would notice that even for some patients, 5 mg per hour is already intolerable or very painful for them. What more is 10 mg per hour? So the rate of infusion should not exceed 20 unless paralysis or malignant ventricular arrhythmias are present. So what about in food? So commonly patients would ask, could we correct our potassium levels by just taking in food? Well, the answer is yes, but in reality, you would have to consume a lot of food just for you to get around 25 millimoles of potassium. So you have to have 100 grams of your dried feeds or weeds, seaweeds, molasses, just for you to get around 25 millimoles. So if you want to correct that, that's just about 2.5 tablets of your Kalium durul. It's a very small tablet. If you wish to have even more potassium in your food, that would be those with a very high potassium content. That would be your dried fruits, your dates, your avocados, your brown cereals, your nuts. So that has about 12.5 millimoles per 100 grams. So again, you have to consume 100 grams of nuts or 100 grams of avocados in order for you to get 12.5 millimoles. So it would be easier for us to correct potassium levels by having the patient consume tablets rather than consume large amounts of food, which sometimes they would not be able to tolerate. Okay, so this would be my last slides. And in summary, hypokalemia is a common clinical illness, a clinical condition that is generally defined as a potassium levels less than 3.5. So disorders of potassium balance are common in clinical practice and are generally the result of disturbances that affect the internal distribution of potassium. So either intracellular shift or because it is induced to be excreted through the renal, through the urine. The cause can be determined in most cases with the knowledge of the clinical setting, the volume status of the patient, the acid-base balance of the patient, history taking, knowing if the patient is consuming certain medications that may induce hypokalemia, or assessing if the patient has poor intake resulting to hypokalemia. So correcting the underlying cause is very important in order to avoid recurrent episodes of hypokalemia. And when we do decide to correct the potassium levels of the patient, it's always safest for us to correct the potassium levels orally, okay, in the form of tablets or syrups. But if the patient could not tolerate it, or if there is a need to rapidly correct the potassium levels of the patient, that's the time that we could consider giving the patient intravenous potassium. And with that, I would like to end my very short lecture. And thank you, everyone, once again, for your time.
Okay, thank you, Dr. Cabigan, for the very comprehensive and interesting topic for hypokalemia. Is there any questions from the virtual floor? Due to limited time, we can only allow one or two questions from the virtual floor. Doctor, the question here is, in hypokalemia, it goes bradycardia, and hypokalemia is tachycardia, which is more also morbidity and mortality event if they left untreated.
Hi, sir. Hypokalemia is typically associated with more of the ventricular tachycardias. So the hyperkalemia is the ones that related to bradyarrhythmias or bradycardias because of the changes in the responsiveness of the myocardium to stimulation. Which one of them is more fatal? Either one may be fatal for the patient, depending on how high or how low the potassium levels is. So both of them can lead to death. It's really hard to say which one is worse because both of them are potentially dangerous situations, especially for patients who already have a pre-existing cardiac condition. So either way, we have to treat them appropriately. Okay.
Thank you, Doctor. Thank you.
Yeah. Do you have any drug-drug interaction?
Other questions, Doctor? Do you have any drug interactions? Watch out for
For the electrolytes, the potassium correction is only actually a potassium chloride tablet. So would there be there's basically minimal, if any, drug-to-drug interaction with the potassium supplements or potassium tablets. So we can correct it anytime through oral supplementation for patients who could tolerate or who could swallow tablets in order for the potassium to be corrected.
Okay. From Dr. John Pulsa, can oral rehydration solution supplementation help in correcting a mild hypokalemia and minimizing symptoms?
Okay. It depends on how much potassium is in oral rehydration salts. I think the potassium content of that is quite low as well. It may contribute to help if there is only mild hypokalemia. Let's say if it's only about 3.2 or 3.3 serum potassium, then it might be able to help. I think it's formulated in order to correct mild electrolyte imbalances for patients who have large volume losses. Now, probably another question would be would advising patients to consume banana improve the potassium levels of the patients? As you can see from the previous slides, we saw that while there are some food that would be able to provide potassium for patients, the volume of the food that the patient has to consume in order to have sufficient potassium levels to correct hypokalemia is relatively large. Like, for example, if we're going to consider bananas, before the medium-sized banana, so a medium-sized banana has about 400 grams of potassium. A Kalium-Durul has 750 milligrams of potassium. So 400 milligrams versus 750 milligrams. And the Kalium-Durul has about 10 mex equivalent from that 750 milligrams in one tablet. So for a patient to have 10 mex of potassium, he or she would have to consume two at least medium-sized bananas in order to have just 10 megs of potassium. So if we're going to correct moderate to severe hypokalemia in patients, they would really have to consume large amounts of bananas or large amounts of fruits high in potassium just to be able to correct the hypokalemia of the patients.
Great. Thank you, Doctor. Thank you for spending your time with us. We have for the awarding of certificate.
All right. Okay. Thank you also, Doctor, and thank you for inviting us to speak on potassium this afternoon. And congratulations for a wonderfully worked out seminar.